Okay, so here is cranial nerve 2, the optic nerve. It carries visual sensory information. This cranial nerve originates in the retina of the eye. It passes through the optic canals, which you can see, of the sphenoid bone. The optic nerve contains 1 million sensory fibers or axons. You'll notice on the picture that the medial fibers cross at the optic chiasm. So that means that when we get down to beyond that chiasm to the optic tract, that half of each eye is supported by the optic tract. So again, you can imagine as you look at this picture, where would the tumor be or where would the brain bleed be, and which field cut would be lost depending on where that damage is, right? These fibers then continue to the thalamus and then to the occipital lobe in the back of the brain for interpretation of visual information. So again, the question remains, where is the damage? Is the optic nerve damaged? Is it damaged, which optic nerve, the right or the left? Is it damaged after the optic chiasm? Or is the occipital lobe damaged? And if the occipital lobe is responsible for interpreting the visual information, right, the information coming from the eyes might be intact. But when that information gets the occipital lobe, if you've had an occipital lobe stroke, that occipital lobe may not be interpreting the visual information properly. Versus the occipital lobe might be totally intact, but you might have some visual impairment. Or you might have some damage in the tracts before it gets to the lobe. So the visual information that's arriving at the occipital lobe for interpretation is incomplete or incorrect. So each cerebral hemisphere receives information from the lateral half of the retina on the eye on that side. So the medial half of the retina and the medial half of the retina from the eye on the other side. So with some strokes, we see something called homonymous hemianopsia, where they have a field cut and they might be losing, if you take a look at this picture, and let's say that damage is beyond that optic chiasm, let's say on the left, that means you're going to have a field cut on the left half of the left eye and the right half and the left half of the right eye. So you might be having a field cut. So you might be losing half of each eye for your field of vision, which could be really disorienting for a patient post-stroke. Having a hard time. Hold on a second. Okay, sorry, I'm back. So cranial nerve 3 is the oculomotor nerve. It originates in the midbrain or the mesencephalon, which is, we'll talk about more about the midbrain with our next lecture. It is a somatic motor nerve, so it supplies motor innervation to 4 extrinsic muscles that move the eye and one that raises that upper eyelid. It also provides visceral motor fiber, so visceral again with that autonomic nervous system, and that's happening automatically with that visceral motor function. It helps focus the lens of the eye and adjust the amount of light that comes into the eye. So it helps constrict the pupil from the parasympathetic fiber. So it has both somatic motor as well as visceral motor support. So what else did I want to tell you here? So this again, this ocular motor nerve, the somatic motor muscles, it helps the eye move up and down and medially, and it also helps to raise that upper eyelid so that it's going to help open the eye and constrict the pupil and adjust the shape of the lens. So those are all really important. You can imagine how disabling that could be if this cranial nerve were knocked out. We also have cranial nerve number 4, which is the trochlear nerve. And again, remember, these are all pairs of nerves, one on either side. So here, cranial nerve 4, it also originates in the midbrain. It is the smallest of the cranial nerves, and it provides somatic motor supply to one extraocular muscle, the superior oblique. And that muscle helps move the eye medially and down. Okay, so it's a very small nerve that you can see over there on the side as it starts to come in. So it's only supplying, not only, it is supplying that superior oblique muscle. So we also have cranial nerve number 6 here, and that's the abducens cranial nerve. So I just grouped them together because they're all impacting, they're all in the same area. So the cranial nerve number 6 is the abducens. It originates in the pons, which is also part of the brainstem. It provides somatic motor to one extraocular muscle, the lateral rectus, and that lateral rectus abducts the eye, pulls the eye out to the side. So you can imagine if one or more of these particular nerves that all supply the eye were impaired, what your patient would struggle with. And this is cranial nerve number 5, trigeminal nerve. It's a mixed nerve. Okay, so mixed means what? It's carrying both sensory and motor information. It originates in the pons, also part of the brainstem. It is the largest of the cranial nerves. So it's called trigeminal because it has 3 branches. And you can see those on the side. So the sensory information that it carries, it's carrying sensory information from the face, somatic motor, muscles of mastication. So it's carrying sensory information from the face. It's also carrying somatic motor information to the muscles of mastication, the chewing muscles. It supplies one muscle of the middle ear, and it also supplies afferent, which is that sensory piece, for the corneal reflex, right? And remember that corneal reflex is that blink reflex. So when the cornea is touched, that information is relayed by this spinal trigeminal nucleus, by this trigeminal nerve. So it's providing the sensory part of that corneal reflex, which could be really important. We want to know when there is an irritation sitting on our eye, right? Whether it's something foreign, whether it's our own eyelash, you want to know that, because if not, if you don't feel that, there could be, some clinical responses to that. So this is cranial nerve 7, the facial nerve, also mixed. It's a mixed nerve. It originates in the pons as well. It carries sensory afferents, information from the anterior superior ear and the external ear canal. It is also carrying visceral sensory afferent information for taste from the anterior 2/3 of the taste buds, right? So that's going to impact your taste from that area. It also carries somatic motor to muscles of facial expression and the stapedius muscles. It also carries visceral motor to the salivary glands or the tear glands, nasal glands, and it supports the efferent limb of the corneal reflex, so the motor part of that corneal reflex. When we have inflammation of the facial nerve, we have something called Bell's palsy. So you can take a look at the list of all the functions of the facial nerve. If those are knocked out, that means patients can't close their eye, right? So you have problems with, you also have problems with making tears. So you'd have dry eye issues. It could be really irritating. So they're going to have to use artificial tears. Obviously, the tears are what's cleansing the eye, right? Helping to wash away an irritant. So it makes you more risk for injury to corneal injuries. So they often have to wear an eye patch. They have to use lubricating drops for the eyes. And of course, looking at the facial expressions, right? They're unable to contract facial muscles. So that can cause the mouth to droop. That means they can drool. which is, has huge social implications. They can have difficulty eating and speaking. And when the face is kind of disfigured, that's very socially distressing for patients. They don't want to come out. They feel really isolated. So, of course, this Bell's palsy can be, usually it can be impaired by inflammation from a virus, and that causes inflammation on this nerve. Doctors tend to treat this with corticosteroids to decrease the inflammation on the nerve, or even an antiviral drug. Most people tend to have a good recovery in about 3 months. It takes a long time, though. 3 months is a long time to not have facial reactions, having difficulty with taste and a variety of impairments.